question. And firstly, you can have a pathological head impulse test in a central lesion. Namely, if the root entry zone of the eighth cranial nerve or the vestibular nucleus is affected by the stroke. You can even have, and we published a case together with colleagues from South Korea and the US, have a pathological head impulse test in patients with a cerebellar infarction. And therefore, a pathological head impulse test does not mean this is peripheral only. It can also be pathological in central lesions. But the reverse statement, if the head impulse test is normal, it will not be peripheral, is true. It's a little bit complicated, but I think you understand it. To put it again, you can have a pathological head impulse test in central lesions. If the head impulse test is normal in acute vertigo with nystagmus, it will not be peripheral.
Vâng, xin hỏi giáo sư từ Thái Lan. Xin hỏi kinh nghiệm chẩn đoán điều trị chóng mặt ở những bệnh nhân bị đột quỵ tuần hoàn sau, đặc biệt là khi các dấu hiệu thần kinh khu trú là bình thường.
Yeah, this is very important point. Actually, for the posterior circulation stroke patients, sometimes they presented with vertigo only, and they still don't have any real neurological deficits that you can demonstrate at the beginning. So actually, Professor Stroke mentioned yesterday, I also use the same criteria for red flag signs for vertigo. The first one would be the headache, would be the acute vertigo, which never happened before. So the first time vertigo that happened mostly in elderly are the ones with risk factors. Second would be the vertigo with headache. So if the headache is at the back of the head, especially comes with vertigo, for the first time, that's a very critical patient that you need to really examine further. And the third one would be the relationship with the position. For BPPV, there are some position related, right, when the patient's rolling around on the bed. But if the patient's complaining of having vertigo when they sit up and they got better when they lie down, that's another important point that I usually concern whether this patient's having a central vertigo. So other minor things would be like history of double vision. Sometimes we can't really examine the abnormalities in the eyes, but if they come in with double vision during the course, that's another thing that we should consider. So these are the ones that I would consider having more further investigation. And please be aware that if you do CT scan in these patients, it may turn out normal, because sometimes in posterior circulation stroke, the first CT may not show anything. So we have to be very careful and follow the patient up. Even MRI can be normal if they come in early.
Vâng, xin thầy Lê Minh Kỳ tóm tắt lại dùm có một câu hỏi này. Thì thầy tóm tắt lại dùm là gặp một bệnh nhân bị rung giật nhãn cầu tự phát, thì làm thế nào để biết được là nguyên nhân là từ trung ương hay là ngoại biên?
Thank you for the question. For spontaneous nystagmus, when nystagmus unidirection and very one side, very unilateral, maybe the peripheral vestibular disorder. And in the other hand, with the multi-directional and bilateral direction, maybe the central disorder. Dr. Michael.
Okay, so in terms of peripheral and central nystagmus, the most difficult constellation is a horizontal torsional nystagmus, which can be peripheral and central. And then you have to re-evaluate the patient history and look for other central signs, like a skew deviation, like a gaze-evoked nystagmus. Secondly, as stated yesterday, the pure vertical nystagmus is central. Pure torsional is difficult to identify. We have to be realistic. If you're very good, you might say, this is purely torsional, and this will be central too. Another thing is nystagmus and head shaking. If you have a spontaneous nystagmus and do the head shaking maneuver, and the direction reverses, this is also central. But in clinical practice, these are very rare constellations. As I said before, the most difficult one is the horizontal torsional, which can be peripheral and central, and then it may take a while and reconsideration of your patient. Finally, even experts are not always sure whether it's peripheral or central. So if you do not know it, you have a lot of good friends who don't know it either. So we should not pretend that we know and can everything. We also have our 20% area of uncertainty, which should be a relief for all of you.
Thank you.